Hello, I'm Peter Bovey. You have been referred by your general practitioner to see me about having a vasectomy. Vasectomy is a simple operation which is basically the operation to sterilise a man. Some people are under the impression it's castration, and that's certainly not the case. Sperm is still produced but don't find their way out of the testis because the vas is divided in a vasectomy. Men still ejaculate, they still have normal sexual function, but there are no sperm in the ejaculate following a vasectomy. Both vasectomy and tubal ligation are simple, safe, effective forms of sterilisation. But sterilising a woman involves having a general anaesthetic. It's an abdominal operation done in a hospital, whereas a vasectomy is an operation that's usually done under local anaesthetic in the office. And as such, it's a simpler, safer operation to have. That's not to say that tubal ligation isn't a simple and safe operation, but women have died having tubal ligations. They've had intra-abdominal catastrophes like having the aorta punctured, bowel perforations which weren't recognised leading to peritonitis. A poor woman in Townsville has had clips put on both ureters. All of those complications I've heard from colleagues, so that I know they've actually happened. The worst thing that I've heard of following vasectomy is someone losing a testis. This was hearsay or fifth-hand from a patient. I dare say it was factual, but basically vasectomy is a simpler, safer procedure to have. Basically about this much of the vas is removed on both sides through separate incisions, 3 or 4 millimetres across in the upper scrotum as per this diagram. It's an operation that's usually done under local, but can be done under a general anaesthetic. Unfortunately, I can't offer vasectomy under a general anaesthetic, as the only hospital that I operate in is the Mater, which is a hospital run by the Sisters of Mercy. You're not sterile immediately following a vasectomy. Sperm is stored in the seminal vesicles up above where the vas are divided, and this typically takes somewhere between 5 and more than 50 ejaculations, and time-wise anywhere between 1 and more than 12 months. As a result of this, patients following vasectomy need to continue to practice contraception until you are told that you have a 0 sperm count. I give all my patients a pathology request form and a container for a sperm count to be done at 4 months. Most men will have a 0 sperm count by then, and they're right to stop contraception. Some men will still have sperm at 4 months. They are told to continue with contraception, and we send them another form in a container and get them to repeat the sperm count 1 or 2 months later, and keep repeating the count until the sperm count is 0. The longest time I've seen it take to fall to 0 so far is 18 months. Even if you don't ejaculate at all following your vasectomy, the average sperm only lives for 3 months. So they should have all died out. If 12 months have gone by and you've still got sperm, I'd normally get you back in to see me and examine you and have a talk to you about it. In years gone by, at 12 months if you still had sperm, you'd be advised to have a repeat vasectomy. More recently, the British Andrology Society has issued guidelines for the need for doing a repeat vasectomy. They have described special clearance if a man has 2 consecutive sperm counts more than 7 months following a vasectomy where there are less than 100,000 sperm per mil and they appear non-viable and non-motile, that's considered to be equivalent to having a 0 sperm count. Apparently no men in this situation have caused pregnancies. However, there is a small number of men who do require a redo vasectomy. I guess I do one of these every 4 or 5 years, and this is a small number considering I do 4 or 5 vasectomies a week. I've not seen anyone who still had sperm after 2 vasectomies, but in this situation I'd be advising you to have your partner sterilised. Men can't understand how a vasectomy can fail given that a significant piece of vas is removed and the ends are tied off. Indeed, neither can surgeons. However, the human body isn't like a machine, and all sorts of inexplicable things have been documented to have actually happened. You can have a beautifully done vasectomy by an expert vasectomist and have a failure. There are 3 ways in which vasectomies can fail. Firstly, you might not have actually had a vasectomy, even though you've been told that you have. In other words, something other than vas has been removed. There's nothing else in the scrotum that actually looks like a vas. It's not negligent to fail to remove a vas. Not all vases are easily found and removed, but it's negligent to think you've removed one when you haven't. And that's grounds for a medical negligence lawsuit. This is obviously more likely if you see someone who is inexperienced or hasn't done a vasectomy for quite a period of time. In Australia, this happens about once a year. Secondly, you might have more than 2 vases. The normal anatomy, of course, is 2 vases, one on each side. I've seen one man with none. He had 2 normal seeming testes and a 0 sperm count, and the reason was that he'd been born without a vas on both sides. The testis and vas actually form as different embryological structures and grow together, so it's possible to have one and not the other. I've seen 6 men with 2 testes and 1 vas, in other words 1 normal testis and 1 congenitally infertile testis. All the other patients that I've seen have had 2 vases, but I've seen diagrams and photos in surgical textbooks and atlases of men with extra vases. The usual situation with an extra vas is that it's much smaller than the main vas and not near it, so you're unlikely to see or feel it at the time of a vasectomy. In this situation, you're likely to have a significant sperm count and remain fertile. One of the textbooks said the odds of having an extra vas are 1 in a million, but I'm sure that this figure has been invented by the author. However, it's certainly rare, and I've heard of no cases in the state of Queensland. Both these causes for failure are very rare. The majority of failures as a result of the operation spontaneously reversing itself. Either the vas rejoining, sperm finding a way across the gap, or the vas actually growing back. We don't know how any of these things happen. Animal experiments on vasectomy haven't been done for about 50 years, and the ones that were done weren't very satisfactory. And of course it's impossible to do experiments on humans. The theory is this: firstly, the vas is quite redundant. So although a segment is removed, in some men the ends sit together like this following the procedure. There are many different techniques described to try and prevent the ends being in contact, and I'll discuss some of these in a few moments. Secondly, the vas has a very thick muscular wall and quite a tiny lumen. This slide is a cross-section of a vas, and you can see what I'm talking about. It's not at all like tying off a blood vessel. And I think with some of the failures, the tie is either not tight enough so that the vas still leaks sperm, or if you over-tighten the tie, it can cheese wire its way right through and the bit on the end disintegrate. And if either of these have happened, I'm sure it's easy to imagine the 2 ends joining up and the patient still being fertile. If this was going to happen, it would generally happen within the first 3 or 4 months, and the patient would never get a 0 sperm count. However, it's quite possible to have a late failure. In other words, there are men that have had a vasectomy, their sperm count has fallen to zero and stayed zero for months, years, sometimes many years, and then they've suddenly got sperm back. They've been thought to be due to men where there is a gap and the sperm have eventually found their way out of the bottom end, across the gap and into the top end. This is commonly referred to as a ghost passageway or recanalisation. When looked at with a microscope, there's a channel lined by a single layer of cells. The odds of this happening are probably in the order of 1 in 1,000. The majority of men in this situation end up with a very, very low sperm count, too low to cause pregnancy, and they never find out about it. There's an urban myth that you only need one sperm to cause a pregnancy. In reality, millions are needed because they secrete enzymes that help the wall of the ovum to be broken down so that one sperm can get in. I think a normal sperm count is something like 40 to 300 million. If your sperm count's under 500,000, you're exceedingly unlikely to cause a pregnancy. If you're able to get men who've had vasectomies to come back to have regular sperm counts, a small number of them will turn up with counts of thousands, even tens of thousands, hundreds of thousands, and they stay at these low levels and they never cause a pregnancy. However, pregnancies have resulted from late failures. The risk of having a pregnancy after an initial zero sperm count, I've read anywhere between 1.4% in the gynae literature and 1 in 20,000. The commonly accepted figure from a large UK study was 1 in 2,500. To guard against that, all one can really do is have a regular sperm count, say once a year, and this might pick up a potential for late failure before your partner is pregnant. Of course it might not. You might get sperm back the day after your annual sperm count. In the United States Marines, all Marines who've had vasectomies are told to have an annual sperm count, but nothing is done to enforce it. In practice, 7% of them actually have their sperm count checked annually. In Australia, almost nobody has an annual sperm count. Personally, I don't believe that they should. I think it would be a waste of their money and a waste of taxpayers' money. However, there are people at high risk. In other words, if your partner had been told she might die if she fell pregnant again, or if you'd had a child with an inheritable disease such as cystic fibrosis. Over the years, I've told about a dozen couples to have an annual sperm count and given them forms and containers to have that done, but none of them have ever done their sperm count. I think the form gets lost and the advice gets forgotten. However, if you want to have an annual sperm count, I'm happy to accede to your request. I would suggest that you have it done on the same day every year so that you don't forget. Keep the form somewhere where you can see it and won't lose it, like under a fridge magnet, out of the reach of the tallest child, and do them until your wife either goes through the menopause or has a hysterectomy. I was once referred a patient who'd had a vasectomy by another surgeon who had an annual sperm count for 5 years. It was 0 every year, so he stopped doing them. 8 years later, his wife was pregnant and denying infidelity, and his sperm count was 20 million. And I did a redo vasectomy on him. There's only one sure way of sterilising a man, and I'll let you guess what that is. Women are even harder to sterilise. Marcus Filshie, the inventor of the Filshie clip, a gynaecologist in Nottingham in the UK, who in fact I met, and in fact to his patients he referred to me a few times when I was a registrar there, published a paper about 20 years ago describing 6 women who'd fallen pregnant following a hysterectomy, and they weren't pregnant at the time of the hysterectomy. They obviously had an intra-abdominal pregnancy, but how they fell pregnant in the first place is a mystery. Our local obstetricians often say the failure rate for vasectomy and tubal ligation is the same. However, this doesn't agree with the available evidence. The three commonest types of tubal ligation, namely the Holker clip, the Filshie clip and the fallope ring, have failure rates between 2 and 7 per thousand, as opposed to the risk of a failure in a vasectomy of about 1 in 2,500. So I think the failure rate of vasectomy is about 1/10 that of tubal ligation. Vasectomy is a common operation. 1/4 of New Zealand men over the age of 40 have had a vasectomy. The rate of the frequency of tubal ligation has been falling for the last 25 years. I think in my city, somewhere between 2 and 5 times as many vasectomies are done as tubal ligations. There are almost as many vasectomy techniques as there are surgeons. I think a lot of these are gimmicky. There is the no scalpel vasectomy, the no needle local anaesthesia, the open-ended vasectomy, the fascial interposition vasectomy. The fascial interposition vasectomy is the vasectomy that's been shown to have the lowest failure rate, in which tissue is sewn over the ends of the vas so that they're not able to be opposed. I was taught to fold the vas back and tie the ends facing away from each other. I think both those procedures need to be done through a large incision. If you fold the end of the vas over, it won't go back into the scrotum through a small incision. Metal and plastic clips have been used. Some surgeons diathermy the ends. There are even devices that have been devised to be placed up the lumen of the vas, made out of silicone rubber, or super glue has been injected up the vas. They all get failures, and some of them turn it into a bigger surgical procedure, as I said. About 15 years ago, I came across an article saying that if one removes more than 7 centimetres of vas, that there'd be physical separation between the ends in everybody. This was a cadaver study, and it said that that might require a general anaesthetic and might cause more pain or complications. About that time I'd had my first failure, and I'd been removing 2 to 5 centimetres of vas routinely, and I thought I'd see how feasible it was to remove 7 centimetres. I found this could easily be done under local anaesthetic, and it didn't seem to cause any more pain or complications. So since then I've been removing as much vas as I could. The most vas I've been able to remove under local anaesthetic so far on one side is 17.5 centimetres, and this has been done with only 2 to 3 mils of local anaesthetic. I think the vas is probably like the brain, in that it probably doesn't have any pain fibres in it. Needless to say, the more vas has been removed, the harder it would be to have a reversal done. So I don't promise my vasectomies to be reversible. That doesn't mean that they're all irreversible. Some of my vasectomies have been successfully reversed, but my vasectomies are more difficult to reverse than most other surgeons. But I'd rather be doing irreversible vasectomies than having failures. I've had 2 failures that I know of out of over 3,000 vasectomies. One of these didn't have his post-vasectomy sperm count done, even though I'd given him a form and a container for it and told him to do it. And last time I did a vasectomy audit, a quarter hadn't had their post-vasectomy sperm count done, and this included 1 surgeon and 2 general practitioners. Needless to say, if you don't get your post-vasectomy sperm count done and your wife is later pregnant, it's 100% your responsibility and not mine. The other one had a 0 sperm count, and 12 months later his wife was pregnant. I've seen 5 cases where the vas grew back. I've reviewed the medical literature on this subject a number of times. Certainly, the urogenital tract has a propensity for self-regeneration. but I've read of no articles that described a vas growing back as a definite structure. The first one that I saw, I'd removed 8 centimetres of vas bilaterally, and after 6 months the patient still had motile sperm and a significant sperm count when I re-explored his scrotum under a general anaesthetic. On one side there was a huge gap, and on the other side there was what looked like a normal vas with 2 ties 8 centimetres apart. I was astonished. I took this out along with a centimetre on either side, sent the vas off to the pathologist, and the report came back as a normal vas with 2 ties on it, partially including the lumen. The second one, I'd taken 7.5 centimetres out bilaterally, and once again on one side there was a huge gap, and on the other side there was an intact vas, but this time the ties were 2 centimetres apart, and the vas between the ties was half the diameter of the rest of the vas. I sent this off to the pathologist, and the report came back saying a regenerated vas with 3 lumens. The third one, a similar scenario, but this time the pathologist said a structure resembling a vas, but they couldn't see a lumen. But after I took it out, the sperm count fell to 0. And in the fourth patient, both sides grew back, 9 centimetres on one side and 10 centimetres on the other. I'm sure this isn't uncommon. It probably results because of my technique where I incise the sheath around the vas, an excise vas, but don't remove the sheath, and presumably it grows back in much the same way as a nerve can grow back. One needs to discuss vasectomy reversal, obviously. This is obviously the last thing on your mind, presenting asking for a vasectomy. Nonetheless, men do come back wanting to be reversed. 3% of Australian vasectomies get reversed. But if you're under the age of 30, you're 12 times more likely to ask for a reversal. Obviously, the commonest reason is divorce and remarriage, closely followed by your partner changing her mind. I think that's called the female prerogative. Then there may be a change in circumstances, either good or bad. Unfortunately, some people lose their wives or their children. Or you might win lotto or get an inheritance or a promotion at work. Vasectomy reversal involves a general anaesthetic and microsurgery. Usually both sides are joined up. In Townsville, this is done by the urologists or the plastic surgeons. If they are able to find the ends of a vas and join them up using microsurgery, they usually get sperm back about 90% of the time. But a success is not getting sperm back after a reversal, it's having another child. The national success rate in terms of fathering more children in Australia is only about 30%. There are a number of factors that are important in this, namely your age and general health, but also the time interval between the vasectomy and the reversal. The reason for this is that following a vasectomy, autosperm antibodies are produced by most men. These are probably physiological. Obviously, sperm are still produced by the testis, swim around inside the testis for their 3-month life cycle and then die, but obviously the sperm production rate must slow and the sperm death rate must rise because the testis stays its normal size following a vasectomy. Autosperm antibodies presumably have a role in this. They tend to get more and more as time goes by, therefore the longer the time interval between the vasectomy and the reversal, the lower the chances of success. If you have a reversal in the first 2 to 5 years, there's probably a 75% chance of having more children, but if more than 10 years have elapsed, this falls to under 25%. If you're in this situation, or if you've had more than 10 centimetres of vas removed, and it's unlikely the ends could be brought together, there is an alternative. The obstetricians who do IVF can harvest sperm directly from the testis with a needle under local anaesthetic and then use them for IVF. Because the sperm is selected and implanted directly into the ovum, it's much less dependent on the time factor. I've heard of success rates between 15 and 50% with 3 cycles of IVF using those sorts of techniques. I think with technology improving all the time, their success rate will improve in the very near future. Both these techniques aren't covered by Medicare and most private health insurance funds and are quite expensive. I've heard of out-of-pocket expenses anywhere between $2,000 and $7,000. In Australia, only 1/3 of vasectomy reversals have more children. The other 2/3 have effectively wasted their money. The procedure of vasectomy itself takes about 15 to 20 minutes to do. Local anaesthetic is just put in the scrotum, not into the testis. The scrotum is not particularly sensitive. You can feel a pulling sensation up in the abdomen as the loop of vas is pulled outside the scrotum before it's excised. There are no sutures to be removed. There's a dissolvable stitch under the skin at the end. The main side effect of vasectomy is bruising. The scrotum is very loose tissue, it's like an eyelid. Putting in local anaesthetic can be enough to cause a bruise. I'm sure at least half the men get a visible bruise, and about once or twice a year I'll see a really large bruise following a vasectomy. I tell patients to go home, put their feet up, put a bit of ice or frozen peas on their scrotum, and try and not overexert themselves for a few days after a vasectomy. If after a few days there's no pain, swelling or bruising, you should be right to go back to normal activity. I've had to drain 7 scrotal hematomas following vasectomies over the years. One of these was done by a GP and 2 were done by colleagues when I was on call. The other 4 were vasectomies that I'd done. So I've had 4 hematomas out of over 3,000 vasectomies. How does one get a hematoma? Well, it happens when one gets arterial bleeding start sometime after a surgical procedure. Whenever you cut tissue, you cut through small arteries, veins and capillaries. The veins and capillaries usually stop bleeding on their own or with light pressure, and they are the cause of bruising, and it's a hematoma which will be caused by a small artery bleeding. In the scrotum there are arteries in the skin, in the dartos, which is the muscle layer of the scrotum. It's the thing that contracts in cold weather. And there's a named artery on the vas itself, the accessory testicular artery. There's also the main testicular artery and vein, but they're away from the vas and normally not at risk of being injured. And I'm talking about arteries 1/2 to 1 millimetre diameter. If you injure an artery that size, what normally happens is that it goes into spasm and stops bleeding after a few seconds. And by the time the spasm's worn off, the bleeding point's clotted and nothing happens. But sometimes spasm can wear off prematurely, or you can dislodge a clot and start bleeding a few hours after the procedure. That's called reactionary hemorrhage, and that's a risk for every operation. That's the reason that 1% of children are returned to theatre bleeding following a tonsillectomy, and 3% of people following coronary bypass surgery. And if that happens in the scrotum, that can give rise to a hematoma. I've had one patient come back bleeding from one of his wounds 6 hours following a vasectomy. That was caused by a bleeding artery in the skin, and that just needed a stitch through the skin to stop the bleeding. But if the bleeder is in the dartos or on the vas itself, you can get a hematoma. Obviously, if you had progressive pain and swelling, you'd need to come back to see me. And if you had a large hematoma, you'd find yourself being admitted to hospital and possibly having it drained under a general anaesthetic and being sore and swollen and bruised and off work for a few weeks. There are some things that you can do to decrease the risk. Firstly, there are some drugs that increase the risk of bleeding. Warfarin, Plavix and aspirin are 3 common oral drugs that can do this. And there are some new ones, Xarelto and Pradaxa, which are replacements for warfarin. By aspirin, I mean Cardia Cardioprenor Asterix, one of 100 milligram aspirins. If you have a couple of soluble aspirin for a headache, that won't make you bleed. But if you take half an aspirin a day for a fortnight, or if you take Cardia Cardioprenor Asterix regularly, you are at increased risk of bleeding. It's said that all the anti-inflammatories and omega-3 fatty acids are also associated with an increased risk of bleeding, but I don't think the evidence is nearly as strong. Heat and alcohol can make arterial spasm wear off prematurely. When you go home following your vasectomy, I advise you to have a cool or a cold shower rather than a hot shower, and if you get sore, put an ice pack on rather than a hot pack. It's fine to go home and have a beer, but if you get drunk, you're at increased risk of bleeding because ingested alcohol causes arteries to dilate. That's perhaps one of the reasons why drunks often have red noses and ears. Or you might dislodge a clot by coughing, sneezing, straining on the toilet, lifting something heavy. In the long run after a vasectomy, it has no effect at all on your sex drive or libido. If you feel carefully along the vas, you might be able to feel a lump where the bottom tie is. You won't feel the top one, it'll be up in your groin somewhere. Epididymis swells up following a vasectomy in most men. It can swell up on one side or both sides or not at all, and the swelling can vary from day to day, week to week, month to month. If I examine someone who's had a vasectomy, I can nearly always tell that they've had one, but often the patients aren't aware of the change because it's so subtle. Men who've had vasectomies are more likely to get an infection in the testis later in their lifetime. We call that epididymoorchitis. It's not at all uncommon in normal men, but if you've had a vasectomy, you're statistically more likely to get this than someone that hasn't. The reasons for this aren't terribly clear. Possibly it has to do with the interference of the lymphatic drainage of the testis. Typically with epididymoorchitis, you'll wake up with a painful swollen testis and you might have a fever. The treatment for it is antibiotics. Usually oral antibiotics are sufficient, but occasionally in a nasty case, this might need to be intravenous and you might require hospitalisation. And if you're going to get this following a vasectomy, it can happen anywhere from within a week of a procedure to 30 or 40 years later. Over the years, I can remember 8 or 9 men coming back with epididymoorchitis within 3 months of their procedure. I've also had one man come back with scrotal cellulitis. One of his wounds got infected and then he developed cellulitis of the scrotum and he needed hospitalisation and intravenous antibiotics. Some men form a hard lump in the scrotum following a vasectomy that we call a sperm granuloma. They're caused by an inflammatory reaction to sperm that have leaked out, presumably due to a transient build-up in pressure. Typically they take 5 to 10 years to develop, but they can occur at any time. They usually don't need treatment, just reassurance. But you do need to be diagnosed, in other words, you need to be examined, you might need an ultrasound scan. Occasionally, if they're painful or enlarging or a nuisance, we treat them. Anti-inflammatories are usually tried first, and if this doesn't work, occasionally they'll need to be excised. This means excising the lump, not the testis. Over the years, I've excised 2 sperm granulomas and I hadn't done either of their vasectomies. I've been asked if there's a cancer risk from vasectomy. The answer to that seems to be no. Many epidemiological studies have been done. I remember one published about 20 years ago from the States where they said there was a 3% increased risk in prostate cancer following a vasectomy. Subsequently, it turned out that they got this result because they hadn't matched the control group properly and there was a different proportion of Negro Americans in the 2 groups, which apparently explained those results. Subsequently, no other study has shown any increased risk. If one is to compare vasectomy with taking the oral contraceptive pill, one of the main alternatives. Taking the pill increases a woman's risk of getting breast cancer by 30%, and this risk falls back to normal within 3 months of stopping the pill. In Australia, 1 in 11 women in Australia get breast cancer, and a quarter of these die from it. I think the risk of taking the pill is thousands of times the risk of having a vasectomy. When you come to see me for a vasectomy, I'll take a brief history from you and examine you, and then we'll get you back to do the procedure. I've been asked if there is anyone that I won't do a vasectomy on. I've done vasectomies on teenagers, I've done vasectomies on single men, I've done vasectomies on couples with no children. I'm happy to do a vasectomy on anyone that really wants one, that is rational. The teenagers had vasectomies because they had serious inheritable diseases. I'm not happy to do a vasectomy on someone where their partner or wife is not in agreement. I think that it should be a joint decision. Consequently, my consent form includes a section for the wife to sign. Questions that you should ask a surgeon you're referred to for a vasectomy are: how many have you done? How many would you do in a typical calendar month? How many failures of vasectomy have you had? And how many scrotal hematomas or major complications have you had?